So good to see, good to be. It is I am Dave, and this is my nursing channel. Welcome to it. To be a nurse, to be or not to be a nurse. Today we're doing a bit of a vSim here. We're going to be looking at Carl Shapiro. This channel is all about Sims study and preparing for real life. So let's see what we got here and go for it. All right, let's see if
Carl Shapiro is a 54-year-old male who presented to the emergency department a couple of hours ago with complaints of chest pain, diaphoresis, and shortness of breath. He was admitted to the progressive care unit with the diagnosis of non-ST elevation acute coronary syndrome for close monitoring. He has a history of hypertension and states he takes a water pill for his blood pressure. He is traveling for work and does not reside locally and came to the ED by ambulance when the symptoms began. No family is present. He was treated with oxygen, 2 liters per nasal cannula, aspirin, 2 doses of sublingual nitroglycerin, and a normal saline bolus required after the second dose of nitroglycerin with no recurrent chest pain. 12 lead ECGs in the ED showed no ST elevation. Antiplatelet and anticoagulation meds were started and documented in the MAR. Mr. Shapiro is alert and oriented ×4. Last set of vital signs was as follows. Temperature 98.2 degrees Fahrenheit, 36.8 degrees Celsius. Heart rate 106, sinus tachycardia with a rare PVC. Respiratory rate 16. Blood pressure 118/78. SpO2, 93% on 2 liters per nasal cannula and lung sounds clear. Pain level was rated 0 out of 10. Labs drawn in the ED are in the chart. BMP, CBC, PTT, INR, and BNP are within normal limits. I have not seen the troponin I results. Vital signs are every 2 hours. Oxygen is ordered for SpO2 less than 90. Serial troponin levels should be drawn at 1600 and 1900. The provider should be contacted about the lab results and to see if a cardiac catheter is planned.
Let's go continues. All right, I've got some quizzes, some questions. Okay. As you prepare to care for your patient, what complications are they most at risk for? Dysrhythmia and cardiac arrest. He's got acute coronary disease or something, so I think it's these two. Could also be respiratory arrest, but I'm feeling like these two. Nice. Okay, let's go see the patient. All right, so here we've got our handover, our SBAR situation background assessment recommendations report. So we've heard about Carl Shapiro. We know his background, high blood pressure. He's a smoker? Not a smoker. All right. So essentially we have to do vital signs. Oxygen is ordered for OSATs, oxygen saturation levels less than 90%. Serial troponin. Troponin is a protein that shows up when there's been heart muscle damage. So we need to draw those at 4 o'clock and 7 o'clock. Medical officers should be contacted about the lab results and to see if a cardiac catheter is planned. Diagnostics is use blood tests. There's nothing that's really... Okay, here's troponin. So troponin's high. Here it is. Let's just have a look on OBS to see if there's good placement of stuff. I think if it's here, we'll have a look, but I think that should be good. All right, clinical observations. So we know to call an emergency call or a MET call, the medical emergency team, if there's any observation in the purple area. Purple area, these are OBS charts. So this is MET call level here. If there's an airway threat, so obstruction, a deviation, a lot of goo or liquid or something coming up there or blocking it, respiratory or cardiac arrest. Let's go back to full. What did I do there? How do we full screen? It doesn't matter. It doesn't matter. Sudden fall in level of consciousness, so if they become confused, disoriented, or if there's a O2 sat drop of less than 90%. Cool, so his last obs were taken at 130, it looks like here, for his respiratory rate. So normal levels here. 16's good. He was a little low before, but it looks like they gave him some nasal prongs with air. And that got him back up to 94%. I imagine that's what happened there. Flow rate, that's the flow rate of the nasal cannula. Okay. It was there attached the whole time. Interesting. Blood pressure was super high, I imagine, when he came in. But he's been given his vasodilators, I imagine, to drop his blood pressure. And now it's looking good. So if the systolic number, if that was to drop here in the 90s, below 90s, I mean, even, yeah, in here, it's a escalation. Okay, so he's on continuous monitoring for heart rate, so that's probably on the pulse oximeter. And we haven't taken his temperature. All right, medical chart, medication chart. Glycerol trinitrate, which is an anti-anginal. I've got my McKenna's drug handbook for nursing and midwifery. So glycerol trinitrate, it's an anti-anginal. Its indication is prophylaxis against angina. And it's a nitrate that reduces cardiac oxygen demand by decreasing left ventricular endostolic pressure, so that's the preload, and to a lesser extent, the systemic vascular resistance, which is the afterload. Also increases coronary blood flow. How fun's that? Alright, regular medicines. Aspirin, it's been signed. He had a dose at 12:35 and 12:35. That was immediately once in the morning. So MANE, M-A-N-E for morning. I don't know what that is, but it's the indications of acute coronary syndrome. That's what he has, acute coronary syndrome. It's our anticoagulant, enoxaparin. Sodium chloride, just to keep his fluids up. Fluid replacement. That was signed at 12:45. Drip rates, radiology, chest x-ray. No evidence of pneumothorax, so that's a collapsed lung. Heart is not enlarged. No signs of congestive heart failure. No areas of consolidation. I don't know what that means. Mediastinum. Orders. We want to do vital signs, so we'll do an A to E assessment. Airways, breathing, circulation, disability, and exposure. We're going to keep the ECG up. We want to continually monitor the ECG and the oxygen saturation levels, SpO2. He's allowed in the bed, bit of chair rest, cardiac diet. I don't know what that means. IVs, medications, loading dose today, then 90 ml tomorrow. Nexaporin, subcutaneous, an injection, subcutaneous every 12 hours. Stab him in the stomach. Cool. 12-lead ECG shows ST to T changes consistent with ischemia, so a bit of lacking of oxygen there. Occasional ventricular premature complexes. Heart rate is 120, pretty high. Normal heart rate is between 60 and 100. We haven't got anything in terms of activity lock, so let's jump into it. We press play down the bottom here. I just want to see what that looks like. Let's move this here. We can see everything. All right. Let's play.
Hi, I'm Dan. I'll be your primary nurse today.
All right, beautiful. So essentially what we want here is we want to ID, check ID, identify the patient. That's important.
Please state your name and date of birth.
My name is Carl Shapiro. I was born on July 19th, 1971.
Beautiful. What we should have done before IDing the patient, the very first thing when you walk in the
Everything
room,
matches.
perfect, is a bit of hand
I'll
hygiene.
wash my hands.
Washing their hands. We would also normally do a safety check, so checking the oxygen and suction on the wall in the room, checking if there's any clutter around the bed, and also checking if the bed brake is on. A very important thing to do here is consent. So we want to obtain informed consent just in case anything goes wrong. Boom.
Hi, I'll explain today's plan for you, and we can discuss any concerns or questions you may have. Is that okay with you?
I have no concerns or questions at this stage. I am happy with the plan.
Oh, beautiful. Not even any questions. He just came out of ED. He's got no questions. It's wild. All right, hand hygiene. Safety check. ID'd the patient. We've got consent. So it feels like now we can go from A to E. A is airways. So we're checking. Look, he's talking to us. There's no obvious signs of any obstruction with the airways. So he's also seems to be talking in full sentences, and there's no signs of distress or shortness of breath. Any struggles there? So I guess we could let's go B for breathing, respiratory. So let's look at his respiratory rates. Actually, let's check his cannula first. Let's assess cannula, IVC. This, right? Isn't it IVC? Assessments, vital signs. IVC? ICV? What is it? Assistance, communication, IV management. Assess IV access.
Let me just assess your IV.
Cool.
Okay.
Okay. Checking for signs of phlebitis, so
The site has no redness, swelling, infiltration, bleeding, or drainage. The dressing is dry and intact.
beautiful. So that's essentially what we're doing.
An infusion of 25 milliliters per hour of sodium chloride 0.9% is running.
And we may as well just check the, maybe just flush the IV and check for patency as well.
Flushing.
Such as pushing some normal saline through just to check to see if there's no, to see if we've got good access, essentially. All right, so let's look at the respiratory rates, respiratory assessments, assess respirations.
He is breathing at 12 breaths per minute. The chest is moving equally.
Very good. So down here, these are all the things that we've got attached. So we've got an oximeter for the OT levels. What is this? That's the ECG. This is our IV access. This is our drug attached to the IV. And we're currently in semi-fowler position. Supine, laying flat, semi-fowler. His arms up a little bit, 45 degrees. All right, so breathing, which is rates, respiratory rate. We want to auscultate his lungs. Auscultate lungs. Listen to heart, lung sounds.
I need to listen to your lung sounds with my stethoscope. Please breathe normally.
Sure.
Let's have a listen. Alright, so this is the right upper lobe. And right lower lobe, left upper lobe, right lower lobe. So we're listening for things like wheezing, stridor, crackles. So let's have a listen. That sounds normal to me. Sounds pretty good to me. Ooh, I didn't know you could switch it back. That sounds good to me. Normal. I mean, it's all good. So they got crackles, rails, wheezing, crackles and wheezing, reduced lung. I don't have a lot of experience in listening to lung sounds, so kind of hard for me to know. Oh, interesting. Okay, cool. Nice. All right, I think what we want to do is we want to attach the automatic blood pressure. So let's do that. Blood pressure, automatic. So you want to keep an eye.
Blood pressure cuff so we can monitor your blood pressure continuously.
Right, because we were looking for that systolic, that top number.
Mind.
If that drops below 90 or even like gets close to 90, that's going to be a little bit of a worrying sign there. Especially if he's, if it's dropping 10 or 20 points in a few minutes or right away, then that's going to be a real issue. So keep our eyes on that. All right. Trachea seems to be midline there. The positioning is midline. There's no deviations. Doesn't seem like he's struggling when it comes to effort, so his effort of breathing is kind of normal. There's no use of accessory muscles, so like up here in the shoulders or the stomach as well. SbO2, the oxygen saturation is looking very nice at 96 right now. And let's check his skin color. Let's just check his skin. Yeah, bruises, rashes.
Check your skin for any bruises, rashes, signs of dehydration, or other problems.
Check to see if he's sweating.
Okay.
I mean, I'm not sure if Carl always looks this pale, but, sometimes that can change.
There is normal elasticity of the skin. His color is normal, and he is not sweating.
Beautiful. So that is B out of the A to B. That is breathing. Now we're on to circulation. Circulation is like if there's good hemodynamics, so a good balance of blood in the system. Heart rate is in normal range, 85. Blood pressure is almost textbook there. So there are two parts of circulation, checking the BP and the heart rate. We also want to check his radial and pedal pulses. So radial is just underneath here, underneath the thumb, about a finger from the wrist. And you can kind of feel it like that. So we want to check his pulses. Check radial pulse first. Checking for strength
I'm going to check your pulse
and
here in
rhythm.
your arm.
So we want to see if it's like a strong pulse, weak pulse, that's for strength, and regularity if it's like...
The pulse is strong and regular at
There you go.
85 beats per minute.
If it's not dun, 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 if the rhythm isn't regular, then it's irregular. That can be an issue as well. We want to check the pedal pulses. The way to do that is you want to follow...
I'm going to check your pulse here in your foot.
You want to follow the web in between
Sure,
the big
go ahead.
toe and then toe next to it. Follow that down onto the bone. I think they just
The
put a
pulse
picture up
is
there.
strong and regular at 85 beats per minute bilaterally.
And when you're checking the pulses, bilaterally means like, both limbs. You want to be checking both sides for balance, essentially. All right, we've checked the pulses. We want to do capillary refill. It'll explain it. It's essentially
I'm going to press on your fingertip to check your capillary refill or circulation in your fingers.
like this. Press down for 5
Okay,
seconds,
That's fine.
and then
The capillary refill time is less than 2 seconds.
I am having that pain in my chest again.
uh-oh. So let's talk to him about his pain. Pain assessment. Do you have any pain?
Do you have any pain?
Can you describe the pain?
Yes, I am not feeling well.
Alright, he's essentially out. What we want to do now is do a Met call. We want to call the Met team. We also want to get some help. We're going to be performing... Okay. What interventions do you anticipate the Met team will perform? We want to perform CPR. Well, they will be performing CPR, analyzing the heart rhythm. I should really look up what that means, but I don't think that's part of it. They want to deliver a shock when advised, administer adrenaline if necessary, and administer amiodarone. Oh, I should really know these things, you know? More homework. I think it's all of these. All right, looking nice, looking nice, looking nice. Cool. Return to patient. We want to perform CPR. We want to get for help.
Shortly.
Want to call for help.
Can we help?
Help.
I'm going to
I
go
need assistance in here
pads. Can we? Yep. Attach shock pads. And we want to start CPR.
We'll start CPR.
We'll place the CPR backboard as well.
1, 2, 3, 4, 5,
Um,
6, 7.
We want to
8,
turn this on.
10, 11, 12,
Analyzing
13,
heart rhythm.
14, 15,
Do
16,
not touch the
17.
patient.
Get him to stand clear.
now. Stand clear.
Analyzing heart rhythm. Shock needed.
Okay.
Charging.
Stand clear.
Press the shock button. Shock delivered.
And now we have to go to CPR.
Begin CPR.
I probably should have done a
3,
full cycle
4,
of CPR
5,
first.
6,
So
7, 8,
30
9,
compressions
10,
to 2 breaths.
11, 12,
And then
13,
maybe
14, 15, 16,
turn on the
17,
defib.
18, 19,
But
20, 21,
so
22,
we've already got a
23,
return here.
24,
We've already
25,
shocked him in his
26,
back, so
27, 28, 29, 30.
I think we're good.
One, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19, 20, 21, 22, 23.
His heart rate's still quite low here.
26, 27,
I'm sorry, his
28,
blood pressure.
29, 30.
Okay, cool. So I think we did pretty good here. I should have probably completed the first cycle of CPR before I turned on the defib and applied that first shock. We'll see what happens. Let's do our handover. SBAR situation, background, assessment, and recommendations. So let's see what options they give us. He had a cardiac arrest, and he is now... okay, that's history, background. Met team was called. I think I'm talking to the Met team right now, so that doesn't really need to be conveyed. And he now has return of spontaneous circulation. So heart rate and BP were happening, I believe. That could be wrong though. He was still unconscious. But he had heart rate. No, I think he still had return of the circulation. Background. No previous known allergies. That's need to educate family. Maybe would go under recommendation. Treated with glycerol trinitrate in the emergency department. He's currently responding with open eye on pain stimulus. He's not doing that though. I think it's just previously no known allergies. I don't think this is relevant. I think it's just no known allergies. We'll see. Assessment. All that apply to assessment. That's background. Normal infusion of... Sorry, an infusion of normal saline is running. And he was alert oriented ×4 before the arrest. I thought that oriented was ×3. Like, person, place, and time, but maybe there's something else there as well. Recommendations. We want to follow up with the medical officer regarding a plan. I think the neurological check should be attained together with the vital signs. This would have been under assessment. Oh, this would have been under assessment. But we do want to obtain vital signs every 15 minutes, so we'll see how we go there. Done. Uploading performance. Let's see how we go. Oh, that's quite good. 86. All right. Case conclusion. The most common dysrhythmia in patients with cardiac arrest is ventricular fibrillation, which is a rapid, disorganized ventricular rhythm that causes ineffective quivering of the ventricles. A common cause of VF is acute myocardial infarction, MI. Patients in VF should receive cardiopulmonary resuscitation, CPR, and defibrillation as soon as possible. When performing CPR, push hard and fast, allow complete chest recoil and minimize interruptions. So this is really important. When you're pressing down, you need to allow the chest to expand all the way back up before you press down again. Otherwise, you're not doing effective CPR, essentially. Effective compressions. Minimize interruptions. So that was a problem there. I'm pretty sure that's where I would have lost marks for minimizing the interruptions. Reassess the rhythm and attempt defib every 2 minutes or after 5 cycles of... Yeah, so reassess rhythm and attempt defib every 2 minutes or after 5 cycles of 32 compressions to ventilations. Ventilations, not breaths. Nice. Immediately after each shock, resume CPR, beginning with chest compressions. All right, let's have a look. Sim performance. Okay, we know no very critical errors. No critical errors, but a couple important errors. Okay. Interesting. I should have auscultated the heart. I would say that I didn't actually get to that. That would have gone under circulation. It's actually not a normal part of the A to E assessment, or at least what we're being tested on right now. So maybe there's more room to be expanded on. I should have asked questions about the characteristics of the patient's pain in addition to assessing the pain level. True. Was that up front or when he actually got the chest pains? Ask the patient if they had pain, checking, yep, not feeling well. Yeah, he looked bad. There was like a change of like face, expression. Asked if they had pain, not feeling well. And then, yeah, well, I didn't really... That's tough. I mean, I didn't really get a chance to even do that. This, I admit, I should have auscultated the heart during the circulation part of the A to E assessment. But he'd already become unconscious at that point. So I could have done this up front. And he had pain, I'm not feeling well. I mean, I didn't really have time, but fair enough. Huh. Okay, I activated Met Team, shouted for help, attached the pads. So attach pads, then start CPR. It just depends, right? Like, you would get somebody, you would probably ask them to get the crash cart. Start CPR, place backboard, turn defib on. You want to report, I forget what AED stands for. Stop CPR, warn, stand clear, shock needed, warn, cloaks, stand clear. Boom, 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 resume patient status. So there was pulse, absent pulse, heart rate came back, pulse came back. Oh, pulse absent. Pulse weak. There you go. All right. Well, I hope you've enjoyed. I'll try and do more of these sims and games and bits and pieces, maybe some live study sessions. Obviously, this is the first kind of real content that I've been putting up apart from the little quizzes. Let me know what you like or what you want, and we'll go from there. All right. Cheers. Big ups. Enjoy. Much love. Stay well. Bye-bye.